So now let's get into some specific client considerations around MAT. So we kind of started a little more globally, and now we're going to get a little bit more specific. But the big picture, right, the reason I think you guys probably came today is this is what you're interested in. You're interested in this continuum of care, and how can you effectively move your client or your patient through the continuum of care. So this is ASAM's continuum of care. Hopefully you guys have seen this, you're familiar with this, right? Outpatient services, IOP, partial, etc. One of the reasons that we want patients to engage in a continuum of care is we know that they're going to have better outcomes if they're engaged in treatment over a longer period of time. So one example of that is we talk about medical professionals, specifically physicians and physician health programs. So for those of you who aren't familiar with it, most states, if you're a physician and you have a substance use disorder, the board catches you before the law does, you get into some kind of program where you're monitored. And part of that monitoring involves participating in treatment, some case management, plans for getting back to work, etc. So these programs range from like 92 to 97% abstinence rates at 5 years. I mean, recovery is a lot more than abstinence, but these programs are really, really effective, and they're also well studied. There aren't a lot of professions where you can keep someone under your thumb for 5 years, so to speak. So the longer your treatment, the better your outcome is going to be. Also, life happens, life changes. In an ideal world, I think a lot of us would say, if somebody's ready for treatment, usually it's pretty bad, and a lot of times they'll just start out at a detox and gradually work their way down the continuum over a period of time. But it doesn't work that way for a whole lot of reasons. And we'll get into some of those in a bit. So this is I just pulled this slide, it's from UCLA, but it's just a graphic depicting a continuum of care. So if we're talking about medical care, say I break my hand. I'm not sure my hand's broken, so maybe I'll go in and see my primary care doctor tomorrow or something like that. Or maybe I'm in a ton of pain and I'll just go straight to the ED and they'll x-ray me and put a cast on it there. Or maybe I'll go to an urgent care and I'll get there and they say, hey, we can't take care of you, you need to go somewhere else. The point is that there's all these different places you can enter, this medical continuum of care. The idea is that in addiction treatment, you should be able to enter wherever you need. If I don't need detox, maybe I can start with outpatient. I have never heard of an interventionist that didn't bring someone to a residential treatment program. They exist, right? But it's just not that common, right? By the time someone, a family is paying somebody to come do an intervention, oftentimes they've made up in their mind it needs to be residential. It's not, let's start at this lower level care and see what happens. So, let's say I got my hand is it's been mended. I'm likely to get some home care or some physical therapy or something like that, and then I'm back to my normal life, right? So that would happen for like an acute injury, right? But we know that addiction is a chronic illness, and it doesn't always work that way. So, social determinants of health, SDOH. Hopefully you guys have heard of that before. So we're beginning to talk a lot more about population health. And when we look at these social determinants of health, right, they apply to physical, mental, etc. And this is most of us over here in healthcare. And we know that, just any old condition, generally speaking, can be treated in a healthcare setting with about 20 to 25% effectiveness. Because we know that all these other social determinants are going to impact that course of treatment, whatever it is. And this is where we have a harder time coming up with interventions. So if somebody comes to my residential addiction treatment program, I can detox them, give them some education, but they're going to go back to where they came from oftentimes, right? There might be some educational barriers to what they need, might be some financial barriers, other environmental things, genetics, etc. So this is a map. So we're looking at from 2012 to 2016. These are Voigt providers. So are you guys able to see the bottom? So basically white, all these little white specks on here, In 2012, they didn't have any providers, and they continued not to have any at 2016. The blue is the same, right? They had providers in 2012, they have them at 16. The yellow, like this is the growth. These are the new places that have sprung up since 2012 where people can get BUP. And then finally, the red areas had BUP and now they no longer do, right? Kind of looks like those cell phone maps, you look at for coverage. There's a lot of white on there. So if I'm treating a patient, it's important for me to know where they are, where they're going. You can't get methadone in Wyoming. There's no methadone in Wyoming. Those folks have to come down here and go to a surrounding state. And this is 2019. So let's shift and talk a little bit about some financial considerations. So availability, we just looked at the map, right? It's critical that we're planning a course of treatment, 1 to 2 years minimum. And if a prescriber decides that BUP's appropriate for a patient and they live in rural Wyoming, are we doing them a disservice just starting them on BUP and then they're going somewhere where they can't get it? Or, are they willing to drive 2 hours, right? So we got to kind of weigh this. When we talk about cost, another thing that we see frequently around finances are when folks come into treatment, it's not uncommon for them to have changes in their coverage or their insurance. When we incarcerate folks and their Medicaid stops, it doesn't always start day one when they get out. There's some legislation around that in Colorado that we're working on. But the prior auth thing as well is a big thing. So we no longer have prior authorizations for BUP for Medicaid patients. But the private insurers, that still is a thing. And the reason I mention prior auths is they're time consuming and difficult. You could be on hold for an hour. And if you're a prescriber, do you really have an hour to sit on hold for every new patient you see that's BUP appropriate? Not so much. I think there's a lot of well-intended prescribers out there, but that just wouldn't work. If everybody had to sit on the phone for an hour when they prescribe for somebody BUP, we're going to see less people getting prescribed BUP. Is Dr. Schuler out there today? I lunch with Dr. Schuler yesterday, and I promised him that I would talk about this. So, one of the things I did last year that was new and different and scary to me was I went and testified in front of one of the subcommittees down at the legislature on House Bill 1269. The reason I'm saying that is it was terrifying and I didn't die, and I encourage you all to do the same. These interventions that we're doing, they can't be contained to just the scheduled visit we have with the patient, right? There's like social justice and legislative things that we could be doing. So my experience with doing that was super cool. And it was scary, but the bill ended up passing. And that bill did a lot of things, but one of the things that particular bill did was it made it mandatory that January 1st in Colorado, all of our insurance carriers have to put one medication on their bottom tier for substance use disorder. We're still a little unclear into exactly what that's going to look like, but the idea is we're getting rid of all the prior auths, no more prior auths, and people should be able to get these medications just like they would, amoxicillin or something like that. So this is my call to arms, my charge to you all. Consider, getting involved with some of that stuff. It's important, and I learned a lot. It was super cool. So copays. So when you think about copays, right? Like a lot of us maybe, you go to your primary care doctor, and if decent insurance, maybe it's $25. But a lot of the folks that we work with, it's not like they go in once, get an eval done, they're put in Suboxone, and they come back 6 months later. They might be coming back a week later. They might be seeing a provider weekly just for the BUP, but all these other issues that are coming up, these other medical issues, our patients a lot of times, they'll end up going to a lot of doctor's appointments. $25 adds up real quick. Medication copays, we have to consider what's the full picture look like for our patients that are getting involved in medication-assisted therapy? UAs are another thing. So are UAs administered in the physician or prescriber's office? Are you using a third party? How much is that going to cost? Is that another $25 every week, or whatever the frequency of the UAs are? And then the treatment conditions. So we see this a lot with impaired physicians. So they'll have a physician monitoring program that'll say, you completed X amount of treatment, we want you to go into an IOP program, and it costs this much amount of money, and the physician isn't working. And they don't have a lot of savings, and they legitimately can't afford it. So if I'm a prescriber, am I unwilling to work with them because they can't afford this other level of care that I recommended, or the physician health program recommended? So environmental considerations. So when we're talking about the patient, what does safe storage of medications look like? So if any of you heard Rob Ballack, he did the keynote at the beginning. He had a graph, a slide up there that indicated, I think it was like 60% of folks, that are misusing or addicted to, prescription opiates started by, diversion from someone else's tablets left over from, a surgery. So safe storage means a lot of different things. It means we don't want other people, to overdose, and I'm not so worried about you, but, oxy, etc. But it also means, I need to be responsible and track my own medications. And a lot of folks, in treatment, they're not going to necessarily the most healthy, productive environment, They might be going to a sober living or a halfway house or, some other less than ideal scenario. So having safe storage is pretty important. Some prescribers I know will not prescribe it unless someone has a lockbox from Amazon, that you can get for $30. Diversion pressure. So this is another thing that Dr. Dan Vivo said I could share that's a little bit controversial. Anecdotally, he told me that it's very common for somebody's first experience with treatment to be on diverted bupe. I've never seen a counselor, never been to any treatment. Their first experience with treatment is someone gave them diverted bupe to bridge them from getting sick. I'm not judging them, I'm just saying that's a common thing that happens. And some of the stories that we get are, I tried my friend's bupe, and I realized that maybe there's another way, maybe there's another option. That's why I'm here seeking treatment with you here today. In my book, that's a win. That's cool. My preference would be that they go through the full continuum of care, be monitored for 5 years, etc., right? However, that's just not realistic. So the diversion pressure that our patients are experiencing, it's not always like malicious, like I want to make money and I'm selling my films on the street, but that does happen. What are the peer groups and what's the home life look like? Oftentimes they come from places where the partner uses, son, daughter, whoever, right? Someone in their home uses, and they're dope sick. And we have this new person in recovery, sounds Suboxone. They want to do good things, especially when they hear about making amends and all this other business. And they're thinking, well, I'm helping this person. Their judgment's probably not all intact, especially if they're new in recovery. But we got to consider these diversion pressures. It doesn't really have to do with intent, it has more to do with circumstances. So this is probably the biggest problem my organization has, is the inclusion and exclusion of support groups. So particularly, we'll talk about traditional AA, for example, right? There's different schools of thought. One school of thought is if you're on medication-assisted therapy, that's an outside issue. Other folks, you're not in recovery. I'm not going to get into that debate. That's a whole other presentation. However, we know that people do better when all of their needs are addressed, including recreation, their social life, their peer support group. So being involved in some kind of pro-social activity is really, really critical. And it doesn't necessarily have to be 12-step. However, 12-step has gained a lot of momentum because it's free. All the barriers we talked about so far, it's accessible. It's virtually everywhere, right? There aren't really any requirements for membership other than the desire to stop using. We've seen kind of an explosion, I think, in the past 10 years of alternative groups popping up. Yesterday, someone was telling me about a AA meeting in Boulder. Right or wrong, said, hey, we're gonna accept people talking about MET here, and we're gonna be MET friendly, and it's okay to do it in this particular meeting. It was an organic thing that popped up, and it's happening, and I think that's excellent. We have, in Colorado, we have a group called Phoenix Multisport. I don't know if you guys have heard of that. It's been around for almost 10 years. But basically, this group got together and said, we're not worried about all this, meds and spirituality. We just want to live a healthy life, and so let's create a safe place where people can get together. And their only requirement for membership is not to have used within 48 hours. That's because they don't want people going through withdrawal while they're doing all the crazy sports stuff that they do. But this particular group, they do all kinds of marathons and triathlons and jogging clubs. So they engage people totally outside of what we might think of like a traditional 12-step group. But other peer support groups, there's religious-oriented ones. Right now, we have a new support group that popped up in Colorado about a year ago called Sober AF Entertainment. And their deal is they throw tailgates, sober tailgates for people involved in recovery. So they're not tied to any organization. All you gotta do is show up and tailgate. But anyhow, as we talk about MET, there's a lot of stigma around this. And it's one thing for me to say, hey, I think you'd be appropriate for MET, but at the expense of you only have 2 AA meetings in your town and they're going to judge you and it's not going to work. What's more valuable, being able to do those AA meetings or be on MET? That's a tough discussion to have. And I don't have the answer to that. I think it's very individualized. And then lastly, family attitudes. So we saw from our survey earlier that family attitudes are have a big influence on somebody's decision to be on MET or not. So I think some of the best things that our treatment teams can do is to engage the family around making decisions around MET. So here's a scenario. We have a 19-year-old adult, but the parents are paying for residential treatment, and the parents don't want this person to be on MET. But the adult patient, makes an informed decision with their prescriber that they want to be on MET, and then the family threatens that they won't pay for continuing care because they don't approve of MET. Right or wrong, that's a real decision, so that's a real tough call for us to make. There's some treatment programs around that are not MET friendly, that are phenomenal treatment programs, like long-term treatment programs that could be accessible to someone, give them a year of like some amazing treatment, but not MET friendly. So again, we got to make that judgment call, and that's difficult. So I'll talk more about not making decisions in a bubble. Ethical principles in counseling. You guys have seen this. There was some stuff on this last night. So from the ethical perspective, just consider kind of patient choice. Because it doesn't mean that everyone that walks into the office says, I want to be on MET, means they get MET. But let's work with them. So one of the things that I've learned, medication, just general medication, right? Medication for a chronic condition. So many of us have chronic conditions. We might take a medication every day. Have you ever missed a dose? Medication compliance, just for the general public, is like 50%. Most folks are not going to be able to take their medication every day. So if I'm talking about autonomy and I'm working with a patient that's always losing their Suboxone on the bus, for example, or they're intentionally diverting, etc., they're impaired. They're not making good choices. I talked a little bit about the continuing care, kind of paradigm, and the treating on what they can afford. So we've talked about this, all the different hidden costs of the course of treatment, and then individualized. So I want to go back a second and look at. There's a really good definition. Oh, gotta hold it down more. This is worth reading. Justice does not mean treating all individuals the same. So Kitchener, she was actually a professor here in town at DU. She did a lot of work around ethics. But this one-size-fits-all thing, right? I mean, I think we can generally agree that's not the way to do business when there's so many variables involved. So that's this individualized treatment. Two different patients might look the same, but there's a lot of implications that need to be considered. So, clinical decision-making, healthcare is a team sport. Healthcare best delivered is a team sport. So when I think about good outcomes, good scenarios, they're usually involving a team. And it might not necessarily be the team within the organization. It could be, partnering with probation and the PCP and, all these other things. But we don't want to make any of these decisions in a bubble. So some clinical implications. This happens sometimes. But if you think about how people engage healthcare, so like my primary care doctor, for example, I only go see him when something bad happens. So I haven't been there in 2 years. But when I go in there, most of us have an expectation that we're leaving with something. I'm coming to see you because something's wrong. So, like how about some antibiotics or a referral to a specialist, etc. So a lot of our patients, these addiction medicine doctors, these prescribers, they're asking all these personal questions. It's kind of like they're therapists. And the patients don't expect that a lot of times. They're thinking the relationship's going to be, I go in just like I would with my PCP, weigh me, take my blood pressure, take some labs, and I get a script. The med-adherence thing I just talked about, but that's a very important clinical consideration. And then the last one is, we talked a little bit about urine drug screening and the frequency around all that. All these things take time and energy. It's a lot easier to have external testing done, go to Quest Labs so I don't have to worry about touching your pee and sending it in and doing confirmations and all that fun stuff. But a lot of times there's costs associated with that. We're almost done. And then we can do some questions. Practical. So I talked a little bit about some of the issues associated with transitions of care. We're doing a real good job, and internally we know ourselves. We know what our organization's doing, from the administrative staff all the way up to the actual prescriber. It's really important to know what other folks, other organizations are doing around town. I referenced a treatment provider earlier that was a great treatment provider, but they said, oh, we're not going to take him on MAT. A couple of years ago, that same treatment provider was like anti-naltrexone. They wouldn't take people on naltrexone. And then they softened to that. But they wouldn't take people on Vivitrol. They softened to that. So we're seeing people kind of changing their position. So now is a real important time to be knowing what's going on with all these other organizations that could be awesome resources to your patients. And then continuity care with the initial provider. We've touched on this a little bit, but the idea here is, how did the person get to me? I think there are a lot of times we have the tendency to be real confident in our abilities and skills, but as a counselor, as a clinician, a lot of times when I would take a history and talk to someone and say, what counselor number am I? 10, 15, 20, right? Like, I'm a blip on the radar. I'm just a small piece of the puzzle. But it's important that we know where our patients are coming from. So if we're going to send them back to the referring provider, it'd be insane not to consult with that person when we're looking at planning out a course of treatment. They might have already planned it out and saved us some trouble. So coordinating with them could save us some time, actually. And then the last one, the patient investment. Substance use disorder, right? Motivation changes. One day I'm really, really sorry and I'll never do it again. Next day I'm doing it again. Or by the minute, or by the hour. So that we can expect that patient investment in treatment is going to change over time. So we have to expect that. Coming up with a lot of really hard, fast rules doesn't always work that well. So, order of operations, kind of bringing everything that we talked about together. This is Jay's order of operations. This is not empirically validated. But what I would urge you all to consider, start with the patient preference. Man, this is the bane of me. Start with the patient preference. What are they willing to do, right? Help them make an informed decision. Involve other people in that decision, in their current support network, family, etc. Access to care is the next thing. We're coming up with this beautiful treatment plan, and they're living in the middle of Wyoming, and we're telling methadone's part of that. It's just dumb, right? We need to take a little bit of time and know what's going on in the ecosystem that the patient is coming from. And then the environmental considerations that we talked about, namely being the family, living environment, etc., finance, all those things. They're super, super critical. So, back to little Noah. So this is Noah after he finished his first, I think it was a 5K. The 5K when you're 6 is like a marathon, by the way. So he finished his first 5K. And the reason I show this is the story we started off with Noah is, he was sad because he didn't think he could move and bring his toys. He successfully moved, he brought his toys, it all worked out well. But some of the things that, my sister did, engaging him around the move, letting him help pack the box, going to see the new house, all those steps she took, I think it kind of mimics what I'd like to see us as a field do when we're using MAT. Let's use all these different things that we've discussed today so we can help patients have the most successful transition to care. So that is it. So with that, I will open it up to questions. Or we can end early too. Any questions at all? Okay, thank you very much.